lacrimal gland. Remember how we said that the pterygopalatine ganglion will give innervation to palatal glands, pharyngeal glands, nasal glands, whatever, blah, blah, blah. Great. But it also gives innervation to the lacrimal gland. So how would you know things? If the patient comes into your office and they have the following symptoms, where might a lesion be? Okay, well the symptoms are going to tell you things. Okay? So first off, if they've got loss of lacrimation, somewhere on the pathway of this parasympathetics we're going to talk about. I know that's a dub, but just realize that. Versus, let's say the lacrimal nerve itself. What does the lacrimal nerve itself do? Sensory to the skin, kind of like right up here on the lateral superior or eyelid, right here. So if you had a loss of sensation right here but no other symptom, where must a lesion be? Lacrimal nerve itself, B1, something like that or whatever. Lacrimal nerve. Because it's sensory only. It means you're before the hitchhiker comes on. The pathway from the pterygopalatine ganglion to the lacrimal gland is ganglion. Postganglion artery will come up onto V2, hitchhike onto the zygomatic nerve, go to the zygomatic-temporal nerve, onto the communicating branch, lacrimal nerve. Okay, so let's think about this pathway here. What do we have to be concerned about? Zygomatic, zygomatic-temporal, lacrimal, and maybe V2 itself, I guess I could say. Maybe in the ganglion. Let's just blow up the whole ganglion. That's my version of doing some awesome graphics and sound. Okay, so if you lesioned, let's say at V2, after the hitchhikers come on, so right before the zygomatic split, so the hitchhiker's got to be on. Well, what all symptoms would you have? Obviously, you'd be affecting infraorbital too, right? Everybody see that? So where would I lose sensory innervation to? Some teeth, but then a big area of skin, right? Where does infraorbital innervate? Below the eyelid, the lower eyelid, skin here, down to the upper lip, lateral part of the ala of the nose, that kind of thing. All right? So if a patient comes into your office demonstrating those sort of symptoms, wouldn't you immediately know that either infraorbital or V2's got to be involved? Just say yes for my purposes. Yeah. Yes. Yes, sir.
Does infraorbital also innervate the mucosa under the upper lip?
Mucosa under... I'm not going to tell you no. You want me to include everything that... I apologize. Yes. Anything you've learned about the infraorbital nerve, yes it does. Okay? I apologize. I was just trying to do skin. Anything the nerve does could potentially be lost. Okay. What happens if we have a lesion on the zygomatic nerve? Let's say I'm on the, for lack of a better way, it goes to the or let's say if I were to lesion at the infraorbital fissure, what am I going to get? Infraorbital nerve, and I'm getting zygomatic nerve. So, pardon?
Where would it be there, the fissure?
Oh, just make a guess. That's a good spot right there. It's got to be between PSA and MSA somewhere. Okay? Somewhere between where those two are. So right in here. Okay, what would I lose? I'd lose infraorbital. I'd lose zygomatic before it's even split into zygomatic or temporal and facial. I'd lose lacrimal gland. So I'm going to have a deficit of infraorbital, zygomatic, lacrimal gland doesn't secrete. All right? What if the patient comes in and they've got this deficit? They've got no sensory here, and they can't lacrimate. Now we've got just zygomatic or zygomatic temporal. So you talk about like lateral wall of the orbit. So it's getting this stuff. Okay? You understand what I'm getting to here? It's all about the symptoms they have that direct you to where the lesion would be.
Is the total diminished of the lacrimal, or just like partial?
The lacrimal gland is gone. How could you, my question would be, how would you have partial?
Like parasympathetics for hearing or sympathetics?
There would be some sympathetics. I got you. Let's move on. Yes, you would, but I'm sorry. Yeah, let's go on.
Dr. Spears.
Yes.
How do you differentiate between zygomatical facial and zygomatical temporal?
I guess we would have to give you a specific site of, that's where, knowing that little distribution, zygomatical facial is more right at the zygomatic bone, whereas zygomatical temporal is going up. But I'd say they both kind of go up. little. Okay. Okay. I want to make sure that everybody understands that the palatine nerves, whether it's greater or lesser palatine, and actually even nasopalatine nerve, are sensory nerves. They have autonomics that will hitchhike onto them, but the nerves themselves are sensory nerves. Alright, sensory to the palate, as their names will suggest to you. I guess that's coming up. I already talked about that. Let's go
Come
on.
directly off B2, right?
If you'd like to say that, yes. I'm not making that statement again. Already talked about that. Okay, for palate, I think everybody, I've already mentioned this or whatever. Palate is all motor from 11 by 10 except for tensor grelli palatini, B3. Sensory to the palate is all V2. Doesn't matter what palate we're talking about, it's all V2. So it's going to be greater, lesser, or nasopalatine. So nasopalatine, here's where the incisive foramen would be, by this little incisive papilla. So it gets basically the incisors canine. Greater palatine is going to get the rest of the hard palate. Soft palate is going to be by lesser palatine. Alright, so palate, V2, and it's 3 different branches, and no one understand that distribution. I forgot. One other region that you probably should know, walls, would be ear. So kind of know what's lateral wall, medial wall, anterior wall, posterior wall. Make sure you know and remember there are 2 muscles inside the middle ear, tensor tympani, stapedius, so that's 2 different innervations. Tensor tympani being V3, stapedius 7. Yes, ma'am.
Just back on what we talked about before, do you want us to know the retromandibular region? Or retromolar, what, that region that, it was like a
Well, there's
section, but we didn't, he wasn't really mentioning past, but it's like a retromolar.
Yes.
Like, do you want us to know all the walls of that?
The retromolar region?
Yeah,
Yeah,
talking
let's
about
go
walls.
with that, wall.
Seriously?
Yeah.
The answer is no. I think the lecture, in that lecture, didn't talk about that
He
at all.
never mentioned it when he went through it, but.
Yeah.
But it's on the,
Okay, no. What's important for you to remember about retromolar region was what? Lingual nerve and its pathway relative to it. Okay. So, tensor tympani, V3, stapedius, 7. Also know, nerve-wise, we got this structure inside the middle ear called the promontory. On the promontory is going to be the tympanic plexus. The tympanic plexus containing, I think it's the next slide, has this tympanic plexus of nerves that's both parasympathetic and sympathetic. So you've got cranial nerve 9 providing the parasympathetics, postganglionics from superior ganglion being the sympathetics part, but it all forms that plexus on the promontory itself. Okay, our good friend. When I'm in the PowerPoint mode, actually, here, let me do this. Okay. Let's talk about facial nerve in here for just a moment, okay? Now remember, facial nerve coming off from the brainstem is a mixed nerve. Motor, sensory, special sensory, parasympathetic. Okay. So first off, we taught you about, there were 2 different nuclei that you had to learn about this, that were parasympathetic nuclei. Lacrimal nucleus, superior salivatory nucleus. Okay? Those nuclei have only neuronal cell bodies for the parasympathetics for cranial nerve 7. It has nothing to do with sensory, nothing to do with motor. They are parasympathetic nuclei. Everybody understand that concept? So it's like, where would the first neuronal cell body for the submandibular gland be located? Superior salivatory nucleus. Where would the second cell body be located for that? Submandibular ganglion. What about for the lacrimal gland? First one's in the lacrimal nucleus, second one's in the pterygopalatine ganglion. I like that. I just made a few sphincters constrict there, didn't I? It's not trying to be complicated. All I want you to understand is where's the first parasympathetic cell body found. Edgar Westphal for 3, lacrimal superior salivatory for 7, inferior salivatory for 9. That's all you got to know relative to what you knew before.
Can you repeat that?
Edgar Westphal for cranial nerve 3, lacrimal and superior salivatory for 7, inferior salivatory for 9. Now let's put the ganglia with it as well. So if I'm Edgar Westphal, where am I going to? Ciliary ganglion. If I'm the lacrimal nucleus, where am I going to? Pterygopalatine ganglion. If I'm the superior salivatory nucleus, where am I going to? Submandibular ganglion. And if I'm the inferior salivatory nucleus, where am I going to? Otic ganglion. Yes, ma'am?
Did we talk about 10 at all ever?
We did not talk about ganglia of 10. Okay, we talked about 10 a lot. Okay, so all I'm trying to get you to understand is sitting back here in the brainstem is a lacrimal nucleus, a superior salivatory nucleus. All right. If I'm a lacrimal nucleus, where would my axons be headed? They'd be coming down, going through this cranial nerve, coming over here to the geniculate, whoop, going that pathway, going out the hiatus of the facial canal, greater petrosal nerve. Okay? The greater petrosal nerve is a purely parasympathetic nerve. Alright? If I'm the superior salivatory nucleus, how are my axons traveling? I would be sitting here as a superior salivatory nucleus, my nerve fibers would come out, travel through the facial nerve, go past the geniculate, go down here, and then they go into chorda tympani and travel that pathway. Okay? If I am a special sensory taste fiber on the anterior 2/3 of the tongue, how am I traveling? I'm out here at the tongue. I travel this way, come up chorda tympani, travel in the facial nerve, go up. Oh, but what do I have? I have a neuronal cell body sitting right here in the geniculate ganglion.
Uh-oh.
Because I'm a sensory nerve. Where's my cell body? In the geniculate. And then the rest of the nerve just continues right on along to the brain. If I'm something sensory, I think the only thing really is kind of general sensory we taught you for the facial nerve was something relative to the ear. Okay? Internal ear. How am I traveling? I'm out here somewhere. I travel in, travel up. Where's my cell body? Geniculate ganglion. Yes, ma'am.
You had said in regards to the greater petrosal, that was the hiatus, or you just said hiatus to the facial, or is that the same thing as?
I said hiatus of the facial canal is where the greater petrosal nerve goes back into the cranial cavity. Okay? Now, yes?
Geniculate is just like what our dorsal root ganglion are, and
Taylor, I couldn't have said it any better. I will tell you, the geniculate ganglion, the trigeminal ganglion, it's just like a DRG. It's where sensory neuronal cell bodies reside. Okay? Other axons, there's tons of other axons traveling through the ganglion. Parasympathetics. Motor goes right through. Okay? But the only cell bodies in that ganglion are sensory cell bodies. Where are the parasympathetic cell bodies? Either back here in 2 nuclei or out in the periphery in 2 ganglia. Alright? So, if I have an insidious virus that wipes out all cell bodies in the geniculate ganglion, what will I lose?
Sensory.
Sensory and special sensory taste. Anything sensory would get lost. So the same thing occurs with the trigeminal ganglion. You have the trigeminal nerve, there's the ganglion, it splits into the 3 divisions. If I have an insidious virus that wipes out all cell bodies in the trigeminal ganglion, what have I lost? I've lost everything except for the motor part of V3. I lose everything V1 does, everything V2 does, and all the sensory of V3. Think back to this. What did I say a ganglion was? A collection of neuronal cell bodies outside the CNS, and there are 2 types: parasympathetic, sensory. Anything else is going to be what? The nucleus back in the brainstem.